So I think we can start the next session. I'll invite with me Dr. Ajit Hazari, Dr. Sudhakar, Dr. Tanvi, and Dr. Ikeda. Please come.
I'll see you at when are you coming to the hotel or you want to rent something?
So I think we'll invite the first speaker, Dr. Sheetal Brar. Is she here? I think Dr. Maipal wants to go early, so second speaker is Sir Dr. Maipal. Okay, you're ready. So we'll take our second speaker first, Dr. Ramesh Babu Babali, and tips and tricks for better outcomes in toric IOLs.
Mics. Switch on the mics. Okay, fine. Shall I start, sir? Yes. Yeah. Good evening, everyone. I thank AIOS for giving this opportunity. I'll be talking on tips and tricks to achieve better results for toric IOLs. I don't have any financial interest. Quality of the vision is poor in the case of astigmatism in the bright light as well as dim light. They see lots of contrast and data blurring and ghosting of images. If you don't treat these patients with toric IOLs, means you're losing significant amount of income by these patients because astigmatism, prevalence of astigmatism in these cataract patient is more than 1 to 1.5 is 18% and more than 1.5 is like 22%. So by improving the quality of the vision to them, we can improve the satisfaction rates. To understand this one, we need to understand about SIA, keratometry, IOL formulae and toric calculator. Keratometry, always better to use automated, and newer ones like topographers or optical biometers. If you include these keratometry readings for SIA calculation, that will give better results. SIA calculator, we use Warren Hill SIA calculator online because SIA influence the refractive outcome. Mainly width is the main factor for this one. We need to know about these incisions, how much they induce astigmatism. That we need to know, and we need to know the mean, median and centroid. For this one I will be showing these are the values we need to enter: right eye or left eye, date of surgery, age and incision location, and the type of incision and incision size we need to calculate, and we need to enter the data, and we can enter any comments also. We can save by saving this one. We will be knowing the astigmatism status like this. You can see all the astigmatism y axis and x axis, total SIA it will come, and we can see the reports. If you get a decent amount of data, I am now looking for 2.8 mm incisions. This is the left eye, this is the right eye. The mean, it's coming for mean values are coming for left eye, it's 0.59 and 0.45 for the right eye. In the median, it's 0.5 for left eye and 0.28 for right eye. The incision size entered here is 2.8. And centroid, these values are important, especially if we are using Barrett IOL calculator or Alcon toric calculator. We need to enter these values. For 2.88 incision, I am getting a SI of 0.16 in the case of left eye and 0.08 in the case of right eye. Whereas you need to know about this one. Whereas coming to 2.2 incision, there are 32 matching records. I am getting more astigmatism when compared with 2.8. Only small incisions work better in very soft cataracts. Otherwise, you will get more amount of astigmatism when compared with 2.8. You need to remember while calculating SIA, while planning for cataract surgery. So, coming to IOL formulas, as you know, within the normal axial length, all of these formulas work very well. Extremes of axial length, most preferred one nowadays is Barrett 2. Toric IOL calculator, we can, with the IOL formula, we can calculate the spherical power. But if you use APRSA calculator, online calculator, we can get IOL power also. So, I always calculate APRSA as a latest one, toric calculator version 2 of Barrett. So, that will give spherical power as well as the this one. Toric calculation also it will do. We need to enter the keratometry values. If you don't have an instrument which can't measure PCA, then we can tick predicted PCA. Otherwise, if you have an instrument which can predict the posterior corneal astigmatism, you can enter the values from this one. See, this is how it shows. The eye, we need to select predicted PCA. If you have any instrument which can measure PCA, you can enter that one and you can enter the data like this. Then you can get a printout like this. Here it's chosen T4 lens of 18.5 lens. For optimum results, I prefer minus 0.35 spherical equivalent residual in these cases. So, the simplest way I do is in this manner. I preoperatively mark intended axis. I don't usually make horizontal. I directly mark the intended axis for the IOL implantation. After putting the paracrine, we need to ask the patient to look into the slit lamp beam. After putting paracrine or after drying the conjunctiva, we can mark nasal side and temporal side. And everybody has, we don't need to use high-end equipment, markerless systems. Simple smartphone app which have a gyroscope. Everybody has nowadays simple phones everywhere. So we can use for iPhone we can use a Toricam app. We can use this is developed by Graham Barrett, and we can, after marking, we can verify the accuracy of the axis. We can take the photograph and after placing the lens we can compare, and we can rotate the IOL accordingly. For the Android, we have different apps like iToric and Crystal Toric. There are many apps. We can everything works very well. Every app works very well. So you can depend on these things. No need for high-end equipment like this one. This is how surgery is being done. This is a high-Q toric lens. This is a horizontally I am giving an incision. Side port is made, then the capsule is stained with trypan blue. Chamber is filled with viscoelastic. Now capsular access is being done with the bent 62 needle. I usually aim for 5 to 5.5 mm rexis in these cases, all toric cases. There was a tendency because of viscoelastic, there was a tendency to extend periphery. We should, in these lenses, especially torics and multifocal, rexis should not go run away. So hydrodissection is done, and by flip and chop maneuver, phacoemulsification is being done. We need to protect the endothelium sufficiently so that endothelium, we can protect the endothelium well with help of dispersive viscoelastic. Cortical aspiration is being done with coaxial IA. Then the IOL is IQ toric is now will be implanted. First we need to, this one is implanted into the bag. Now the viscoelastic removal, just 2 clock hours shorter than the required placement, we need to remove, we need to place the lens. This is the horizontal axis, this one is the intended axis here. After removing the viscoelastic from anterior and behind the IOL, then the IOL is rotated to the required position. This viscoelastic is removing from the behind the IOL. Now you can see the lens is, yeah, it's done. So we need to make sure that chamber is watertight. Any loss of the any loss of fluid that can cause shallow of the chamber, that can again rotate the lens, then it will alter the results. This surgery was done way back in 2013. This was the result. If there is any change in the lens position, again we can fix that one by using astigmatismfix.com. Thank you for your kind attention. Any questions are welcome.
I just want to add one thing. Very good tips, because these are some things on the Barrett calculator which we don't look at, but you can take something which is there on the calculator called an integrated case. So you may want to look at the toricity of the cornea with maybe more than one machine. So they give a mean as well as a median.
We can enter many values in that one. That has an advantage.
Maybe just add 3, it gives a median.
Yes.
If you add 2, you get a mean. It's a good idea to look at the median, and that may give you a different axis from what you were expecting.
Yes. There is an advantage of Barrett calculator.
I didn't get how 2.2 is causing more astigmatism than a 2.8 incision.
Obviously, it is causing more thermal damage to the wound.
There are corneal wound burns.
Yeah, there are many people say that one. Maybe. I don't know. They won't say in public. They have noticed. Few people have noticed. In my study, I got clearly. So nowadays, I don't do torics with 2.2 incision.
But that would depend on the tip that we are using. If we are making a 2.2 incision, then our tip would vary as compared to a 2.8 incision. The idea is that we need to have a watertight incision without any leak, and if it's wound burn happens typically when we use a lot of energy.
Not clearly the burn, actually. There will be some subclinical damage might be there. Thank you.
So we'll have the next speaker. Dr. Rishi Raj Singh is here. Okay. And sir, Dr. Mahipal wanted to go after this. Can you take the next? You can prepare on the other one. And Dr. Rishi Raj Singh is going to be speaking on unhappy post-cataract surgery patient. What next?
Good evening, everybody. First of all, I am thankful to RSI for giving me this opportunity. My topic is about the unhappy.
Can we have the timer for 7 minutes, please?
Unhappy cataract patients. With the many advances in the cataract surgery in recent years have led to better outcomes and highly satisfied patients. But still we had patients walking in our OPD after the cataract surgery unhappy. And the cause of the dissatisfaction is mainly the blurry vision. And there are various reasons that may cause the blurry vision. The most important one is the residual refractive error. Everything, distant, intermediate, near, night vision can cause the decreased vision in the postoperative period. It may affect the residual refractive error that causes the decreased vision in the postoperative period. So communicating to the patients ahead of the time is very important. It may lead to a 20/5 happy outcome in the postoperative period, because the blurry vision, it can be anisometropia or it may be due to IOL decentration or the PCO. So anisometropia can be easily corrected either with the spectacles or the contact lenses, or maybe sometimes you may require refractive surgery or piggyback lenses that can correct the residual refractive error. But if it is due to the IOL decentration, you may need IOL exchange or IOL repositioning, or PCO that also affects the postoperative vision, that can be easily treated with the NDR capsulotomy. Cystoid macular edema, another important factor. Sometimes the anti-segment is perfect, but the OCT macula shows there is the CME in the postoperative period, so that can be easily treated with the NSAIDs and the vision can be restored in the postoperative period. Ocular surface, another important factor. You should look in preoperatively about the patient history, symptoms of the grittiness, discomfort and blurry vision or fluctuating vision. There may be history of systemic collagen vascular disease or associated manifestation that may give you clue about the dry eye disease. So the clinical examination, the preoperative period is also very important. Sometimes debris in the tear film, a low tear meniscus height, or you may require standing with the TBUT or Surmas test may be required in the preoperative period, and look with this superficial punctate keratometry that also affects the IOL power calculation in the postoperative period, causes dissatisfaction or blurred vision. So the corneal sensation, especially diabetic patient, there may be chances of the persistent epithelial defect in the postoperative period that also was the frustration, and the dry eye disease as the elective, because of the elective nature of the cataract surgery, should be treated prior to the cataract surgery. Surgery can be postponed till the surface can be optimized. So there are various ways like the artificial tears, and nowadays cyclosporin is also very effective because it avoids the steroid-induced side effects and can be treated easily. In cases of the aqueous deficiency dry eye disease, punctal occlusion can be done after the ocular surface inflammation control. And another important factor is the meibomian gland dysfunction that causes the evaporative type of dry eye disease, and it can be easily treated with topical azithromycin, or if required topical antibiotic steroid combinations can be given. Sometimes tetracycline drugs are effective at least 1 month before the cataract surgery can be started for the control of the meibomian gland dysfunction, and omega-3 fatty acids are also beneficial in the management of lid disease or lid disorders. Like in a patient we operated, vision was 6/6, but patient was not happy, especially during nighttime irritation. Meibography showed loss of meibomian glands, so we treated with the hot fermentation, azithromycin, cyclosporin eye drop, and patient was symptomatically better in the postoperative period. Especially in the patients of the uveitic cataract, topical medication should be tapered slowly because there are chances of the rebound inflammation and causes irritation to the patient in the postoperative period, and this is very frustrating to the patient because the inflammation is recurring in this patient in the postoperative time. Evaluation of the IOL. Sometimes the decentration of the IOL, especially in the EDOF or multifocal IOL, causes glare or halos, or in the toric IOL patient, if there is more than 0.5 diopter residual astigmatism even after the 1 week, then there may be chances of the surgical intervention that can cause the restoration of the realignment of the toric IOL. So evaluate the patient. Sometimes dysphotopsia, either positive or negative dysphotopsia, causes the frustration to the patient. So you have to choose between neuroadaptation versus a problem that requires surgical correction, because in 3 to 6 months neuroadaptation can lead to disappearance of this type of symptoms, but even after 6 months the symptoms is persisting, then there may be lens exchange of some may be required in these patients. So photic phenomena, either due to IOL-related issues, can be corrected, or sometimes pupillary size cycloplegia or bremonitomy may be effective in these type of patients. So sometimes patient is not happy in the postoperative period due to near vision. So the demanding patients or the evaluation of the patient in the preoperative period is also very important. Like a patient we implanted with trifocal IOL, but in the another eye the patient was implanted with EDOF IOL. So patient was not happy with the near vision in the left eye. So avoid mix and match of the different IOL technology in patients. So in the postoperative period, in this type of dissatisfied patient or unhappy patient, communication is the key. So use the terminology that the patient can understand, and in this type of patient, listening to the patient is very important, because it is the first step in working towards achieving a patient's happiness following the cataract surgery. So the challenge is providing the best visual outcome with the accurate IOL power calculation on biometry, choose the best IOL material and type, and proper centration and the orientation of the IOL. So in conclusion, patient expectation, and choose the patient wisely. Selection of the patient according to the personality type of the IOL, and preoperative workup is very important before implanting an IOL for a happy outcome in the postoperative period. Thank you.
Dr. Rishi, in your practice, what is the most common cause of an unhappy patient in your practice as an individual?
Sir, I think irritation, MGD, in the post-operative.
So, if that MGD is not picked up on your pre-op evaluation at the slit lamp, then how do you plan to tackle it in your future patients?
Sir, the most important things that we come across in the post-operative period is the irritation, Cuban Rudkin.
I'm sorry, I'm talking about the pre-op checkup of your patient. If you want to pick up MGD, which becomes apparent later on after surgery, how would you suggest that we pick it up in the pre-op examination?
In the clinical examination is very important. So look for the MGD for the debris in the tear film, or for the irritative frothy discharge at the tear frothy margins.
That would be obvious MGD. I'm talking about subclinical. If anybody else would like to suggest.
Sorry.
How do we pick up subclinical MGD in our cataract patients?
I think the first thing is that patients have irritation, they have discomfort, and nowadays I think OSA, infrared myopography is the most important thing that you need to do. The other thing is we are not concentrating on the expression test. So if you kind of express it, you can get this secretion that's coming out. So I think those are the important things that you have to pick up. And at times the patients come with irritation also because there is sometimes a cyst formation. So if you puncture that, I pretty often do that in the OPD, the patient gets immediate relief.
Okay. So invite the next speaker to take stage and prepare the presentation. Okay, it's Dr. Kedali.
Can I have my slides, please? Thank you. Thank you very much for adjusting me. I'll be talking about a new kid on the block, and that is the enhanced monofocal, which okay. Sorry about that. So basically, when you are looking at today from a monofocal IOL perspective, I think things have changed. We had the non-foldable lenses which were there, then came in the foldable IOLs. I would say that obviously today the foldable IOL is the standard of care because your incision is small, but still in SICS people do the non-foldable. And then from the foldable IOLs, the design and the optical properties have improved. So earlier we had the spherical monofocal lenses, and I don't know why the company still makes spherical monofocal lenses. Obviously there are very few conditions where they are required, and then came in the aspheric monofocal lenses which were there. Now the current day monofocal lenses, as you all know, has the difficulty in patients seeing intermediate and near. That was the problem that we had. Distance vision, obviously you can get good crisp vision with the IOL biometry being pretty accurate, as also you're being able to get the toric intraocular lenses in position. Now as we have moved on, you can see that when the requirements have changed significantly because the lifestyle has changed. So most of us would be needing to drive and then also look at the Google map to see as to where you are, or it comes on your screen. So basically you need distance, you need intermediate modular kitchens, grocery shopping, you have obviously shopping that's digital, online, on computers. Kids are not playing football and basketball and cricket nowadays, but they are doing, most of them, the grandparents as also the kids are working on the video games, etc. Entertainment has also shifted, like instead of going to the large screen, I was watching the television, the match on the phone. So things have really changed significantly from where we were and what we are, and daily activities have become a requirement, where I think majority of the requirements today, you have Kindle and things like that, so you don't actually are reading finer prints, but the intermediate vision has become something which is very important. So as we see, the new advancement that is there is called as the enhanced monofocal. This concept was introduced by the iHance lens, but today I think there are a couple of lenses which are coming in, and now the thing is to get a patient nearer to N8, N6 with maybe a little bit of micro monovision and no photopic phenomena. So that's what we are looking at, and this is the key area, that intermediate vision has now been conquered to a reasonable extent by these enhanced monofocals. So these intermediate visual acuity, which I just said, is something which is very important in the daily activities as per the active lifestyle of an individual. And the outcomes for this particular thing would therefore depend upon what is the expectation of the patients. One important and good thing that I have in the advanced monofocal, it has totally cannibalized my monofocal practice today. I don't really use any monofocal lens today. The cost difference is very slight. So if you're going in for an EDOF lens and you are asking the patient to spend 50,000 rupees more versus in a monofocal where you're asking the patient to maybe spend 5,000-7,000 rupees more, you don't really have to talk, you don't have to do your own brain damage nor the patient's brain damage. But usse patient has come, you just I just put two categories. You want something which will give you good vision for distance, and something which is a trifocal lens. So that's what I talk to the patient, and then basically between the two they decide that's what it is. So the post-op consideration therefore on the patient's outcome etc. would therefore be dependent on what were the expectations, what are the pre-operative consideration, and what is the IOL power selection that you got. So this is a lens that has been made available to us in India, I think about maybe about 5-6 months ago. We still don't have the toric variety, though it's available, and we expect the toric variety to come. So those who have used this Hoya lens, this is based on the Impress, which is also, they say, ozone treated, and the incidence of the PCO is less. The stability is pretty good, you can see, and it has a filter in it. So the Vivinex Impress, which is there, is an aspheric spherical aberration correction, which is tolerant to coma. This is very important, that even if there is some slight decentration, it is tolerant to coma. It is tailored for giving you an improved intermediate vision that you have, and distance visual outcomes are absolutely more tolerant, as also the intermediate to than a standard monofocal, and I'll tell you the reason why it is. Material hydrophobic acrylic, gristling free, no calcification, C-loop 13 millimeter, full 6 millimeter optic, very low PCO, rotational stability for the toric is pretty good. The other important thing that I have seen is the multi-cert preloaded IOL. So all their IOLs today in the Vivinex and the Impress family come as a preloaded lens, and the injector multi-cert is really fantastic. You can even push it through a 1.8 millimeter, so you have a nozzle which goes forward to go through as a wound assisted, or you can go into the wound and do that at a 2.2 millimeter. Now the enhanced monofocal IOL does not compromise on the distance visual acuity, and the incidence of photopic phenomena is similar to that is seen in the patients who have a standard monofocal lens which is there. This is designed to provide maximum depth of focus without significant clinical compromise in the quality of distance vision. So let's just say as to what exactly, how does it achieve this particular thing. So if you look at the center, it is the central 2 millimeter which is there. If this is the side profile, so on the side profile there is no difference between when you are seeing a monofocal or an enhanced monofocal. Now there is, in this central 2 millimeters that you have, there are undulations. That means there is a positive and a negative. So there is a convex and a concavity, and which are very small steps, very, very small steps. It's not a ring or a circle, but what does it do? These positives and the negative will give you an elongated, so it's they call it as a monofocal EDOF or whatever it is. So you can see this is the area or the range that you have, which is achieved not by rings, which was the standard when the Symphony came in as the first EDOF, and now you have, for example, the Vivity, etc. You still have rings. In this particular case, there is an absence of ring, but it is still getting a stretch. And this stretch of it's basically the Strum's conoid that you have. So it's this stretch that you are getting by the positive and the negative that is giving you the entire thing which is there. So this is a novel aspheric design which is designed to provide wider range of function of focus. Enhanced monofocality will mitigate the impact of residual. So basically, when you have this stretch, even if there is some residual refractive error, it will either be in focus here, or it will be in focus here, or it will be in focus here. So that's the basic advantage that you have, and therefore it becomes much more tolerant to any decentration, as also it is more tolerant to any residual refractive error which is there. So this is, I told you about the peripheral region. The profile converges to that of a standard aspheric, which is the negative aspheric that has to provide good distance visual acuity. And there is no split in the light as such. So this is therefore, in case of decentration also, the reduction in contrast is lower as compared to the standard negative aspheric monofocal lens which is there. This is just a comparison between their normal Vivinex, this is the normal Vivinex, the Vivinex Impress and the Technis, and you see that the comparison if you have as to the measuring the contrast across the whole three things between the lenses, it compares favorably. This is the injector system. It can come as a screw type or it can come as a push type, whatever you like, and it is uniquely designed. You have to just put viscoelastic. This comes in a preloaded thing. Just take out the cartridge, push it in, and it's a very smooth and a gentle insertion that is there. I have yet to break a lens or to actually puncture or whatever, or to have cracks in the lens with this injector system that is there. So this is finally what I'll just say, this is the product specification. As of now, it is available from +6 to +30 in steps of 0.5, hydrophobic, UV, blue light blocker, rough haptic surface to give you the, this is a small change that has come between even the Technis and the Technis Toric 2, was that the haptics, instead of being smooth, have been roughened. So that kind of causes stickiness into the capsular bag, and the same thing is here so that you don't get rotation. So this is, friends, goes through 1.7 wound assisted and 2.2 if you actually go in. So this is what I have to say. Early results for 6 months have been great. Most of the patients are getting N8, and if you do a slight monovision, they tend to get on to the N6 which is there. Thank you very much for your kind attention. Thank you.
Dr. Sachdev?
Yeah.
I have a question. How does it compare to the Vivity performance?
So it gives you the same without spending too much. I have really no love or liking for the EDOF. I started with the Symphony, gave it up. Vivity also, I have done a couple of them because the Vivity still has photopic phenomena. So that you guys will be able to, those who have used it can say, and it does not give you an N6. So basically the patient is spending a far more amount of money, and the patient is not getting reading vision. And I feel that with the EDOF or the Vivity as compared to a trifocal also, there isn't a significant increase or a decrease, I would say, for Vivity for the dysphotopsias. So therefore, as I told you, either I go in for my monofocal, I go in for an advanced monofocal, or I go in for a trifocal straight off. So I don't have anything in between which is there, because incidence of dysphotopsias because of the edge treatment of the steps that is there, whether it is in the Zeiss or in the Synergy, or Panoptics doesn't come still to that. I think they're coming out with a new lens. So that the dysphotopsias have gone down. I think a better lens that is available in Australia that has been released and in parts of Asia is called as the Pure C. That is the next generation of iHands. This gives a slight 0.25 more near. That means that your ad goes down to about 1.25 to 1.5 for the near vision, and that's the same that you are getting with the Pure C. Pure C is supposed to be better. So I personally like either this or the trifocal.
So just an observation, you made a comment, why are people still manufacturing spherical?
Yes.
So actually your iHands or these enhanced monofocals are actually you are reducing the central 2 millimeters, you are making them spherical.
No, you are inducing a spherical aberration, but
the whole lens is spheric, but you are inducing again spherical aberrations to increase the depth.
Agreed, but the point is that the periphery of the lens is aspheric or negative aspheric, so that is where the quality of the vision or the focusing, it's basically the peripheral area where the focus is different from the central area.
Yes.
So that's the point. So when you are looking at an aspheric lens, the aspheric lens is definitely, whether it is zero asphericity or it is negative asphericity, but making it a positive asphericity, which all these lenses are, they just price it lower. But there are very few post-laser cases where you would want to go in for a positive spherical, otherwise you don't really need it. Yes. So that's the thing. They are inducing, but it's only in the central 2 millimeters.
Yes.
Yeah. Okay. Thank you.
Very good afternoon to all of you. So I'm going to talk about, we are moving on from premium IOLs to a situation where we don't have a bag, we don't have an anterior capsular support, and what can we do for these patients. So I'm going to talk to you about retropupillary fixation of iris claw IOL, and I'm going to share a few of my experiences with you. So first and foremost, the indications that I commonly use this lens for in my practice. One is surgical aphakia, where we have either been referred a patient from outside, or we've had our own complication and we post them as a secondary surgery for this IOL. Or we have a complicated cataract surgery and we have the IOL power for iris claw IOL available and we can directly implant it. The only difference is, since most of our surgeries are topical, we have to give peribulbar block to do this procedure. A subluxated lens where there are near total zonular, very big zonular weakness, and where the zonules are not intact and it can be salvaged either by a Sionis or a CTR, this lens comes in handy. And patients who have pseudophakic bullous keratopathy and which require an IOL exchange along with an endothelial keratoplasty. So when we are looking at our patients, we need to examine the conjunctival status. If the patient has a glaucoma drainage device or trabeculectomy, we might need to change our incision to temporal. Specular microscopy pre-op is a part of workup for these cases. We need to look at the endothelial cell function and a good anterior chamber depth of more than 3 millimeters. When we are examining these patients pre-operatively, it is important to note the presence of vitreous in anterior chamber and plan our surgery accordingly. And important caveat for these lenses is the status of the iris, and we need to have an intact iris at least 270 degrees to be able to enclave them successfully. If there are large iris defects, this might not be an ideal option. So with this introduction, let's move on to a surgical video. Here, this patient is a case of surgical aphakia. And first tip is that to mark the side port incisions 180 degree apart so that they are exactly at 180 degrees, and to make slightly scleral incisions rather than corneal incision. This helps in mid-peripheral enclavation and avoids the ovalization of the pupil. The second caveat would be to inject pilocarpine to constrict the pupil. That would again prevent enclaving the IOL too close to the pupil and prevent ovalization of the pupil. And then we are staining the vitreous with the help of diluted triamcinolone. And what I like to do is that before I go ahead with the vitrectomy, I create the tunnel, because after we vitrectomize the eye can become soft and it can be a little tricky to create the tunnel. So we typically need about 5.5 millimeters size of the scleral tunnel, because the optic of this IOL is 5.4 millimeters. So initially I am just using the crescent knife, but I am not entering the anterior chamber yet. We are going to keep the tunnel and then perform the vitrectomy so that we have a stable chamber. If we enter at this point with the help of a keratome, we might have a lot of leak from the scleral incision. And then we go ahead with the vitrectomy cutter, and it is essential to make sure that we leave no vitreous in the anterior chamber. We might, for a few cases, we might need to call in our retina colleagues, patients who require a pars plana vitrectomy. Another important thing to remember here, if there are remnants of the capsular bag still remaining and we are going to implant this IOL, we should remove those also with the vitrectomy cutter, because they can get fibrosed over a period of time. So remove, in a nutshell, remove the vitreous, remove any remnants of the capsular bag before you implant this IOL. And the IOL that we use here is a biconvex design, so we are performing a peripheral iridectomy here to avoid a pupillary block glaucoma later on. And then when we come out, since we have done a vitrectomy, I am injecting a viscoelastic from the other side before I remove the infusion, so as to make sure that the anterior chamber is well formed, and we can see we have a round pupil now that we have done the vitrectomy. And then we enter the anterior chamber, and we first place this IOL on top of the iris. We can easily put this IOL inside with a 5.5 millimeter incision. And once we have placed this IOL on top of iris, we can just use a dumbbell dialer and rotate this IOL in position. And these marks help in guiding us now that where exactly the claws need to be. So that tells us where the claws should be and what position of the lens we should keep it in. And the second tip here to know where the claw is once we put the haptic back is to hold with these iris claw IOL holding forceps biceps in the center, exactly where the claw is. So we can draw a line in our mind and we know exactly where the haptic, the claw is. And when we tuck in, we have to be a little gentle. We need to just slide in with the hydrodissection cannula. If we are too aggressive, we might bunch up a lot of iris tissue, or we might cause the haptic of the this claw coming on top of the iris. And similarly, this procedure is being repeated on the other side as well, and we gently just need to make sure we can see the dimpling, which is a good sign to know that we have achieved the enclavation. And also we can tug on the lens a little bit if we are not very sure in the beginning cases, to make sure that we have enclaved the IOL before we come out. A suture may or may not be required. I typically like to place in a suture where I have done vitrectomy, and then in the end we remove all of the viscoelastic and seal our incisions well, and that is the end of this case. Now here is another case scenario where we have a subluxated hard cataract. This is a 75-year-old male who has sustained trauma to the eye, and he has actually been planned for an ICC with implantation of iris fixated IOL. We can see here the capsule is completely wrinkled. It's not possible to do a phaco emulsification or a SICS in a patient like this. So here we have potentially planned for implanting iris fixated IOL, and the IOL power calculation for retrofixation needs to be kept in mind, and the A constant that we need is 117.0 for the lenses that I use here, which are by the Lenseye company. I have no financial interest. The tunnel that I have created here is a little larger to take care of this nucleus, and then again we need to perform a vitrectomy before we implant this lens in position. So here now the pupil is a little mid-dilated because of the trauma. He has traumatic mydriasis, and I am putting a little bit more pressure than desirable, and we can see here that the claw has come on top of the iris. So this can be avoided if we are a little gentle in our pressure. And then the other haptic has been enclaved, and then we close this case. This is another case scenario that I would like to share with you. This patient has been operated for cataract surgery about 25 years ago, and he's come up with a corneal decompensation now, and he needs an IOL exchange along with an endothelial transplant. So when we remove the epithelium, that greatly enhances the view, and we are able to see this IOL very clearly now that needs to be removed from the anterior chamber. And as we remove this IOL, we find that one of the haptics has not come out. So it's very important that we look for this haptic before going ahead with any other additional procedures. And that was finally retrieved from the tunnel as well. And then we are again going ahead with this iris claw IOL, and this can be easily combined with a DSEC procedure. So this is such a fast and quick technique that we can combine it with endothelial keratoplasty with a full thickness keratoplasty, because it does not take more time than we need for scleral fixated IOL. So to conclude, retropupillary fixation of iris claw IOL is a quick and safe procedure in absence of capsular support. This technique is easy to learn. It has a very short learning curve as compared to scleral fixated IOLs, and it can be easily combined with endothelial keratoplasty or even full thickness corneal transplants. Making scleral incisions, constricting the pupil with pilocarpine helps in preventing ovalization of the pupil, and we should try and avoid excessive pressure when we are enclaving this claws to avoid bunching up of the iris and the claw coming on top of the iris. Thank you.
One donkey's ears. Instead of using the hydro cannula, take a Sinski, ask the manufacturer to remove the tip. So it's what we call it a rod. This is a straight thing, and it's much thinner than the hydro cannula. You will push in much lesser tissue, and definitely you will cause much lesser ovalization.
Can I ask a question?
Sure, sir.
We know that these cases can have a pseudophacodrosis. It is fixed with the iris and it is a refracting situation. So the movement is always there. And is there a chance of having more chance for CAB in these cases? Or maybe a little bit of inflammation? What about the endothelial cell loss in the long run? Because whenever we heard earlier, we've seen many cases of Dr. Gandhi Singh where he used to put drugs in the front. And there we had a lot of cases of indefinite decompensation and CAV also.
So with this new generation of IOLs, and we are putting them at a retropupillary plane rather than putting them anteriorly, and they also have an haptic angle to them. There's a 10-degree of tilt in the IOL as well. So all the studies that have been published, most of them tell us that there is no difference in the endothelial cell loss when we compare these with the scleral fixated IOL. And if we look at the endothelial cell count over a period of years, patients who have undergone iris fixated IOL versus the newer generation ones versus the scleral fixated IOL, there is not much difference in the endothelial cell count. CME might be related to the primary indication per se, because these are all complicated eyes. We are not doing them for patients who have had an uncomplicated surgery. So I think a large part of cases that we see with CME is also related to the primary cause why we are implanting these IOLs in the first place. In fact, I have not personally implanted these IOLs in pediatric eyes, but there are a lot of studies now where patients these IOLs have been implanted for pediatric patients, and they have also reported a very low complication rate.
No, sir. No. In fact, our SFILs have more CME compared to this. So definitely endothelium, it's very far off. It's behind the iris. But definitely even CME there, sir. Yes, we've had typically close to 8 to 10 years down the line because of progressive iris atrophy. Sometimes they do come back with one side spontaneous without trauma. Obviously, traumatic distal inclusion can occur anytime, but even spontaneous, we have noticed typically 8 to 10 years. The same thing is happening with scleral fixation. If you use steno, 8 to 10 years down the line, the suture is degenerating. Yes, because invariably it's only one that slips and the other is still enclaved there. So it's very easy. It's a 2-minute procedure to go and re-enclave it slightly next part.
So we experienced a case where we had implanted a customized IOL because we had made for an eye which had a corneal diameter which was only 9.5 millimeters, and that patient had a large PI. She had congenital cataract and had been operated and left aphakic for a long time. So in that patient, because she had a large PI and the iris was defective, one of the claws we couldn't enclave well and it had come out. So what we did was we just passed a proline suture from that side and fixed it to the sclera instead of, because we didn't feel comfortable in re-enclaving this. So that could also be an option in case we feel it's going to come out again. Thank you.
As compared to SFIL, this IOL
Definitely the irido-phacogenesis is noticed, but we don't seem to have too many side effects of that. The patient does not see anything, we don't see increased CME. No patient has complained of such a thing. So I have done this in pediatric, 14 years, now the boy is 20, 25. Absolutely.
Can I have the slides, please? A very good evening to all of you. So I'll be talking about post-operative problem solving after premium IOL implantation. There are no financial disclosures. So the benchmark standard for refractive outcomes for normal eyes after cataract surgery has been that 55% of cases should be within plus minus 0.5 diopter. With increasing IOL technology, enhanced biometry techniques, this no longer holds true. And in fact, 80% of cases are within plus minus 0.5 diopters, and now the focus is shifting from precise visual acuity to optimal visual quality as well. So what are the reasons for post-operative patient dissatisfaction after premium intraocular lens implantation? Residual refractive error in 57%, dry eyes in 35%, dysphotopsia including waxy vision, ghosting, glare, halos in 26%, unrealistic patient expectations in 8%, intraoperative or post-operative complications such as PCR, vitreous loss, inflammation, RD, lens dislocation in 12%, and ocular comorbidities in 20%, which actually are the wrong patients to select for premium eyes. So here I'll be covering a few common reasons for post-op patient dissatisfaction: residual refractive error, dry eyes, and dysphotopsia. So post-cataract surgery, dry eye is almost inevitable to some extent. Vicious cycle of inflammation, tear instability and tear hyperosmolarity, which is worsened by the use of eye drops, age, previous unknown DED and topical antibiotics, etc., surgical time, light exposure. So 9 to 80% have dry eyes at 3 months after cataract surgery. Preoperatively, undiagnosed dry eyes can lead to biometry errors. Postoperatively, they induce higher order aberrations and compromise the visual quality. Prevention, of course, is paramount. You should screen, like we were talking about meibography, and ocular surface should be optimized preoperatively. It's self-resolving in a majority, that's the good news. Topical lubricants is all that is required in majority. However, they may persist in up to 1/3 of patients for 6 months, and the degree of dissatisfaction is much more pronounced with multifocal IOLs. So stepwise management algorithm has been described. You start with lubrication, you start with patient education, modifying the environmental factors, shifting to preservative-free, then you can add on anti-inflammatory, secretagogues, topical steroids as and when required. So just a case example, a 55-year-old female presented 2 weeks post-cataract surgery with a multifocal IOL with complaints of glare and poor visual quality. The visual acuity was 6/6 part, near vision was N8. So on staining there was punctate staining observed and TBUT was 2 seconds, and aberrations, modulation transfer function was deranged and higher order aberrations were observed. So topical hyaluronic acid with polyethylene glycol and propylene glycol combination drops were prescribed with a nighttime gel. So symptomatic improvement after 3 months of treatment, improved tear film and corneal aberration profile, and the patient was happy. Residual ametropia or astigmatism is an essential cause of post-op dissatisfaction and accounts for 29 to 57% of unhappy patients. It may be due to inaccurate biometry preoperatively. Intraoperatively, the surgical technique, the centration of capsulorhexis, how effectively the effective lens position is there, IOL planned for bag placed in sulcus, toric incorrect par or alignment, inverted IOL implantation. Postoperatively, IOL rotation in toric IOLs, otherwise posterior capsular fibrosis, contraction, IOL movement, decentration, tilt. So clinical approach, stay calm and counsel the patient, accurate refraction to determine the residual refractive error, recheck and reperform all calculations. Where did you go wrong? Was it a biometry error or is something else to blame? Check if the correct lens went in. Is the lens positioned right? So management is based on the cause, assess the magnitude of residual refractive error and identify the underlying cause. Conservative management for minor refractive errors, spectacle contact lenses, fellow eye surgery, you may target monovision or micromonovision to take care of minor residual myopia. Surgical management, corneal-based approaches, PRK, LASIK, arcuate keratotomies for astigmatism. Lens-based approaches include piggyback IOLs, IOL exchange, and toric IOL rotation. So post-operative assessment of toric IOL alignment, ray tracing aberrometry is a useful tool which gives you the direction and magnitude of rotation relative to the current IOL position. And in cases in which you have aligned improperly or the lens is rotated in the post-op period, it will tell you how much rotation is required and how much post-op improvement is likely to happen. So in this case, ray tracing says that no further rotation is required and tracy refraction is green. Corneal ablative procedures, LASIK is superior to lens exchange and piggyback IOLs, and a customized ablation or femtosecond laser intrastromal keratotomies may also be attempted to correct residual astigmatism. Of note, you have to wait for refractive stability for at least 3 months after the primary surgery. Lens-based procedures, IOL exchange can be performed in the immediate post-op period, especially if a wrong lens has gone in, more suited for larger magnitude of refractive errors. In premium IOLs, sometimes you need to exchange if there is intolerable dysphotopsia. Intraop aberrometry assisted IOL exchange helps in cases such as difficult cases with post-refractive surgery IOL surprise. So they give you the correct on-table aphakic refraction and help you calculate the IOL par on table. And this was a case of ours in which there was a difficult, challenging IOL par calculation operated from outside of surprise and a post-LASIK case. So post-op day 1 after ORA assisted surgery showed a 6/6 visual acuity. Then piggyback IL are more accurate than IL exchange. You don't need to necessarily know why the residual refractive error occurred. Exchange IL can be placed in a different plane to the original IOL, and it's a reversible procedure. So when you look at the predictability of these intra-op procedures, 62.5% are within plus minus 1 diopter of final spherical equivalent with IL exchange, 85% with piggyback ILs, and 100% of with LASIK. So corneal ablative procedures are most predictable. Now, identify the cause, observe the patients, carefully weigh the risk and benefits before retreatment. Astigmatism more than 0.75 diopter, enhancement may be beneficial. So these are the various procedures as I've already outlined earlier. Prevention, of course, is better than cure, and patient counseling is key to optimal outcomes. Then coming to the third cause of unhappy patients, dysphotopsia, glare, halos, and starburst. The incidence ranges till from 0.2 to 20%. With the newer IOLs, it's much less. However, trifocals still have glare and halos, less with continuous range of vision IOLs, and of course monofocals fare best with these symptoms. Inherent IOL design, decentered IOL, large angle alpha, PCO, lens edge effect may all contribute to dysphotopsia. Management, conservative to start with. Observe glasses, contact lenses. Miotic agents such as brimonidine have been shown to constrict the pupil and help in the dysphotopic symptoms till the time the neuroadaptation occurs. Surgically, rare cases, you can do a YAG capsulotomy if there is a PCO. Then for dysphotopsia, piggyback ILs, IL exchange, sulcus IL, anterior optic capture, and YAG anterior capsulectomy have been described. Most cases resolve with a conservative approach within 6 to 12 months. Determine whether the patient is unhappy due to the PCO or the lens itself. Performing a YAG cap can make subsequent IL exchange technically challenging after a premium IL. So this is another case example, a pseudo fake with complaints of blurred vision and a lot of dysphotopic symptoms. I'll just wind up. Yeah. So the optic was not covered by the rhexis margin nasally and slight decentration of lens temporally. So raised higher order aberration, deranged MTF PSF. So these were the treatment options we have. We just started the patient on topical brimonidine and the symptoms improved significantly at 3 months. So patient counseling is of paramount importance because unrealistic patient expectation leads to a dissatisfied patient and unhappy surgeon. Just to conclude, dry eye disease, residual refractive error, photic symptoms are some of the causes that can lead to unhappy patient. Patient counseling should be performed and avoid aggressive management. Patience is the key to managing these patients. Thank you for a patient listening.
Thank you. That was a very comprehensive talk, and I think we need to stress, and we can't stress enough on the importance of patient counseling. Lots of times we tell our counselors to counsel patients regarding different IOLs, and they might put it differently if we are using eye hands or a Vivity. It's very important that we ourselves tell the patient that we are not targeting near vision, and it's only going to be an intermediate visual correction that we are aiming at. And along with LASIK, PRK can also come in handy when we have a very low refractive error, or it's a case who has undergone RK previously and we need to correct the residual refractive error. Then PRK is another tool which should not be forgotten for these eyes. Can we have Dr. Shreyas please with his talk on aphakia management after complicated cataract surgery?
In the previous talk, Dr. Manpreet told about optimizing the visual outcomes after cataract surgery. Basically, I am a VR surgeon, so I have a rehabilitative role. So I will be discussing on rehabilitation in patients who have undergone a complicated cataract surgery. So basically, my talk is aphakia management after complicated cataract surgery, choosing the right plan. So the incidence of surgical aphakia is less than 1% in modern cataract surgery. Most of the intraoperative aphakia is avoidable if the surgeon is well prepared for such a situation. So coming on to the evaluation part, history is very important. Duration since cataract surgery has to be noted. Associated systemic comorbidities should be noted, just like obesity, claustrophobia, or anxiety, because these might have contributed to intraoperative complications. So in the evaluation, we have to note the best corrected visual acuity. Intraocular pressure should be documented. Coming on to the anterior segment evaluation, we should know the wound integrity. This can be performed through a simple Seidel test. In the cornea, we have to check for the clarity. If any associated DM detachment is there, this can be confirmed on ASOCT. Specular count should be done to note the endothelial status. In the anterior chamber, reaction should be noted. Any residual lens matter in the anterior chamber should be noted. Any vitreous strands should be documented. We also should document horizontal wide to wide. This is important if you are planning for an SFIL. Coming on to further evaluation, in iris you have to look for areas of damage or chafing. If there is any associated iridodialysis, pupil, it's very important to examine the pupil in undilated state and its ability to dilate and constrict. Also we should assess for capsular support, and simultaneously we have to perform biometry if it is not already available. So posterior segment evaluation is also very important. In the vitreous we have to look for any hemorrhage, retained lens matter or dropped IOL. Retinal periphery examination is very, very important to look for any associated peripheral tears. So what are the factors which decide what type of IOL should be placed? It's again the surgeon's preference, availability of a suitable IOL, adequacy of capsular support, the wide to wide diameter, coexistent lens matter or IOL drop, and the timing of surgery, whether it is primary or secondary. So the IOLs currently available for aphakia management include AC IOL, retrofixated iris claw IOL, sulcus IOL. We have either 3-piece or a rigid IOL, and SFL it can be of various techniques, that sutured IOL, haptic fixated IOL, the flanked IOLs, or the newer one, the CMT flex IOL. So we'll see how to deal with this surgical aphakia. We'll go stepwise. The most important part, the initial part, is stabilizing the wound. This is especially important when you are dealing with the posterior segment complication. This avoids inadvertent vitreous prolapse, and also because of vitreous prolapse there might sometimes happen retinal tears or suprachoroidal hemorrhage. So stabilizing the wound is first most important part of managing it. So again now we'll move on to dealing complications of anterior chamber. So we have to do a thorough anterior vitrectomy if vitreous is there. If any residual cortical matter is there, that has to be removed. So when we have defects of iris, or when we have a pupil which is not constructing, sometimes we might need to consider doing pupilloplasty or a iridodialysis repair. So when descent membrane detachment is there, this has to be dealt before planning any other secondary procedures. If the patient has landed up with a choroidal detachment or a suprachoroidal hemorrhage, a simultaneous CD drainage procedure can be planned. So simultaneously, if we have some posterior segment problem like nucleus drop or IOL drop, this has to be dealt before planning a secondary IOL. So coming on to choosing the right IOL, so the most important things which matter are the presence of adequate sulcus support, the wide to wide of the patient, then whether the pupil is able to constrict, and if there are any associated iris defects. So if there is a dropped IOL already we are having, if we have a 3-piece IOL or a rigid IOL, if the sulcus is adequate, we can go for sulcus fixation. If we don't have adequate sulcus, based on the wide to wide, if the wide to wide is of normal diameter, then we can either go for an SFL or an AC IOL. If the wide to wide is very large, or if it is small, we can go for iris claw IOL. If we have a foldable IOL drop, we can explant it, and then either based on the sulcus support we can go for sulcus fixation or an SFL or iris claw IOL. Some surgeons have also designed SFL techniques for foldable IOL where they fix it using sutures. When we don't have an IOL and it's just a case of aphakia and we have adequate sulcus, either we can go for sulcus fixation of the 3-piece IOL or rigid single-piece IOL. When there is no sulcus, again we have to assess the pupillary constriction. If it is constricting, you can go for any of the IOLs, that is iris claw, SFL or AC IOL. If the pupil is not constricting, you can consider for pupilloplasty, and after that again go back to either iris claw, SFL or AC IOL. If there are gross iris defects, then you have to go for an SFL with cosmetic contact lens or for an aniridia IOL. So we will see how a sulcus fixation is done. So most important thing when you are placing a sulcus IOL is that you should have a good sulcus support. At least 2/3 of the good sulcus support should be there, and inferior sulcus support is the most important. So we should always see that we should maintain the reverse S insertion to avoid pupillary block, because we have that anterior 10-degree angulation between the haptic and the optic. So this technique of loading and injecting the foldable 3-piece IOL is very important. First you have to rotate it completely clockwise 180 degree and then again come back anti-clockwise. So these are few techniques of SFIL. There are various techniques. This is a video showing X-nick technique of SFIL placement. This is another video which is showing a rigid IOL which is placed using an X-nick technique. So there are various other methods like Prolene suture fixation, and this is a flange technique of SFIL fixation. So then we have already seen the technique of iris claw IOL. There are two designs. We have a biconvex design and a convex concave design. Convex concave design with the concave surface placed upwards is better. It avoids pupillary block. If you are using a biconvex design or you are placing the convex surface upwards, it is important to plan a surgical PI. So last but not the least, the AC IOL. When you are placing an AC IOL, it is very important to measure the horizontal wide to wide diameter. So your IOL selection will be like approximately 1 millimeter over the horizontal wide to wide diameter. Commonly we have this 12.5 mm IOLs in our Indian market. If it is beyond this, we have to either go for an iris claw IOL or an SFIL. Thank you.
Thank you so much. In interest of time, we will move on to the next talk by Dr. Meher on monofocal plus IOLs. Dr. Indrajit is here.
Good evening, everyone. Most of the slides that I have are already been covered by Dr. Mahipal Sachdev sir, so this will be a repetition. So no financial interest, sir.
So will you just take questions?
As you wish. Yeah. So, yeah. Since the world's population is increasing and the demand for IOLs is naturally rising, more and more patients expect that they'll be free from glasses, and number of premium IOLs are now in the market. It's really an incredible time to be in the cataract refractive space. Previously in the past, patient had no possibility of spectacle independence, but now patient has many opportunities. So how is intermediate vision important in our daily lives? There are increasing number of people who are working on laptops, tablets, phones, playing video games, watching TVs, reading subtitles. All these are where intermediate vision is useful for us. And the global average screen time is 6 hours and 58 minutes per day, which is mind-boggling. The younger generation, that is from 97 to 2010, they spend an average 9 hours per day on their screens. The millennials, that is born in 81 to 96, they spend around 3.7 hours a day on smartphones. And the previous generation, the baby boomers, they are almost 73% of them are active internet users. So necessity is the mother of invention. The industry has found a place for them to innovate, and then came the monofocal plus IOLs. The most commonly available monofocal plus IOLs in the market are now iHands by J&J, Ray1 EME by Rayner, and Envista. There are some more even confusing terminology. EDOF lenses, extended depth of focus. We have the Alcon Vivity, and previously we had Technis Symphony, and we even have it now. And this slide I've just added this afternoon. I've seen when I'm roaming in the trade area. This is a strange IOL. I'm yet to use it, but they say that this is also a presbyopia correcting IOL, where it has to be implanted horizontally, and just like a progressive spectacle, it has distance, intermediate and near zones. It has to be seen how this performs. So a lot of interesting IOLs have come into the market. So what is monofocal plus IOL? It should provide a distance vision comparable to that of a monofocal IOL, and should provide some good intermediate visual acuity, that is at around 66 centimeters from the eye. Previously, the spherical aberration occurs when all the incoming light rays end up focusing at different points, but IOL based on spherical aberration can offer some depth of focus, but it can affect resolution and clarity, making it hard to obtain sharp images. Aspheric IOLs are therefore designed to provide sharp distance vision, but patients will require glasses for intermediate vision. And the zonal design in the bifocal and multifocal and trifocal IOLs can, though they provide good intermediate, near and distance vision, they have a larger halo pattern compared to standard monofocal IOLs and low M2F ratio compared to monofocals. There came IHANS IOL where there are no rings, no zones, no sphericity. It is based on a continuous higher order aspheric surface. There is a local increase in curvature in the center. This difference is so small that it does not affect the shape of the eye. It looks almost similar to their monofocal thickness IOL. And also both these lenses have same thickness in the center, which provides a good intermediate range. Like Dr. Mahipal has said, even this is Vivinex by Hoya. Vivinex Impress by Hoya is based on the same platform, and we even have Swissphobe by Apasami, which is of the same technology. This is a study published in journal where they have compared IHANS monofocal IOL with IHANS IOL with their Technis monofocal IOL, where they have found that it really provided good intermediate vision. And also they have compared, this is another study where they have compared IHANS IOL with similar monofocal IOL, where there is the higher order aberrations and halos were comparable to that of standard monofocal IOL. So intraocular lens designs are constantly evolving. It is important to assess not only the amount of vision provided, but the quality of vision is important. So we have to select our patients very carefully. Choosing the right patient for the right lens is important. Also, we have to explain that cataract surgery is done on two eyes and not just one, and we have to explain the patient that both eyes work together, and also that neuroadaptation is a part of this process, and sometimes it may take up to 6 months for the symptoms to settle down. And also, patients' expectations should be realistic. Patients need to know that there is no technology available to make them 20 years old again, but we have the technology that gives them a very high degree of freedom from glasses, and not necessarily zero, but low side effects. Thank you.
Nice talk. You've included most lenses, but there are a lot of EDOFs in the market. What is your percentage of use in your clinic? How many EDOFs, monofocals, trifocals do you use?
Actually, I've never used Technis Symphony, but VVT, I'm a VR surgeon. VVT I'm using for my patients who want the best IOL, but they have previously undergone a retinal surgery like macular hole or ERM, or some people who have had intermediate AMD or dry AMD. I'm preferring that because to standard trifocal IOLs.
So to the panel, I wanted to say there are so many confusing nomenclatures coming, advanced monofocals. I think the ANSI classification that is given, don't you think they all come under an EDOF category? I mean, an EDOF has so many different ways of working. There's a hybrid EDOF, there is a one which is working with the aberrations, there's a pinhole effect, and many such. So I think just the optic principle differs, but they are mainly giving you an intermediate vision where you can comfortably see for till an 8 and 9 and probably need a plus 1.5 for near. So even all these lenses that you mentioned may even come under the category of an EDOF.
If you have to classify by ANSI, you need to demonstrate at least 1.5 diopters. So things like IHANS or Impress don't give 1.5 diopters. So you'll have to look at residual cylinder that nobody is talking about, the refractive status of the patient when they are measuring these things. You not measure the aberrations. If there is a small coma in that particular eye, he not N8, he'll be reading N6 also.
So we did a study recently with Clarion IOL, which is a monofocal lens, yes. And we found extremely surprising but great results for an intermediate vision. So which made us think, and now we have started that study to look at just monofocal IOLs with a monovision. Of course, we did that with a monovision. Yes. And I think every monofocal lens may give us that kind of an intermediate vision. Why will it change, sir? Why do you think it will change?
Age.
No, but the aspheric lenses, so I don't know about the others, but at least with Clarion we found that it was kind of leaving behind some asphericity. So we saw, I mean, we do a lot of EDOF lenses. I think each in the brand, we've done autofocus also. Maybe.
See, you are talking about pseudo accommodation by the flexibility of the bag.
Fibrosis, capsular
But
fibrosis.
that is the cause of failure of crystalline, but that is not proven, or there is not so much of, the pseudophakic mobility has not been demonstrated to a great extent.
Actually,
So what I'm trying to say is that I think the near ad is not just based on the lens, but like how he said, the other variables, the pupil size, the asphericity of the cornea. So an individual variability is also quite high.
Actually, Indian eyes, since we have brown pigmented iris, and if you look at older patients more than 70 years of age, the pupil size is hardly 2 millimeters, and that can add to a pinhole effect. That could be one reason where your monofocal or an eye hands might give you a better near vision than expected. Second is residual astigmatism. If you have a minor cylinder at 90 in few of your cases, you might notice that really helps in enhancing the near vision. So there are a lot of factors that we need to consider when we are looking at near vision.
Yes. Clarion actually, when it is brought, that preloaded one was normal monofocal. The newer one that is non-preloaded, they are marketing it as intermediate, functional intermediate vision.
But that's true. Everybody needs hot dogs to market.
Okay. Can I start?
Yeah. One observation.
Thanks to AIOS for this opportunity.
One sentence. You said that previously patients had no chance of spectacle independence. I think you've forgotten monovision has been here for a very long time, and it's a very good option, still practiced.
Shall I start? Okay. So we are coming to the last of the presentation. No financial interest. So all these things were already dealt with. I'll just skip them so that we can spend more time on discussion. Main thing as the critical steps are very important, because whatever said and done, prevention is always better than cure. So the IOL initially, even if it rotates or not rotates, we should always try to see that it's in position at the end of the surgery. This is like a continuation for our toric IOLs. So reference marking is also very important, because that is the initial step where we have to be very careful. So even if you go for a digital imaging system, we always tend to mark the patient, because you never know. Sometimes that digital imaging might not register. And suppose you block the patient, it will be even more difficult. So at least take a reference marking, either with the bubble marker or direct freehand marking. So for right-hand persons, temporal will be easy. Nasal marking might be difficult. You have to reassess that again, because sometimes it might not be exactly at that point. Once, if you use a speculum, always remove the speculum, reassess your markings. And on the slit lamp, if you mark it, again reassess when the patient is sitting in normal position. So we have a lot of toric options, just a few videos that is in mid-dilated pupil. So this is an advanced monofocal toric. So to save time, I will run this also in the meantime. So usually most of our surgeries we do under saline. So this is another lens. To increase the rotation stability, they have ridges on that haptics. But this lens, the problem is like inserting into the bag, we had a little bit like hard time to insert. So we had to slowly, gently, with lot of force, insert it into the bag. So these ridges theoretically help in increasing the rotation stability. But we have to be a little bit careful with these lenses. So other options are newer lenses are coming, which have frosted haptics. sorry, I think, so I'll just go through this. There is one more, I think, yeah. So we have these lenses. This is a new one from Toric, Technis Toric. We also have IHANS in this option, in this, which has a more surface texture and friction on the IOL haptics. So this also slide was already presented. It has squared and frosted appearance. So I'll just show the video. Now all the latest IHANS Torics, they are coming as a preloaded versions. So we have to use both hands. We have to rotate with the other hand. That is why we have to inject this under visco. One way it is safer. Always it's safe for the patient. And injection will also be easier. So
there is one which has come with one also. This is a screw injector.
yes, this is coming.
Now there's one with the
Yeah, no, is it coming with a direct? They didn't give.
We are using, yes, IHANS with a direct press injector.
No, they don't have that option. Only screw type they have.
Our preloaded version have only screw type. Even internationally also it is screw type only because the loading and control is in our hand. So in all international we have IHANS, Torics, network, everything is in screw type.
I think for studying it.
Yes, one study is going on. 4 countries. So maybe.
So the same principles we follow. One thing is like when we come to the end of the surgery, like before keeping it position. For this lens, it's always better to take 1 degree anti-clockwise to the intended axis. Not till 5 degrees like as other lenses, because they don't rotate much. And we have to be very careful while rotating. Don't use excessive force. You might sometimes tear up the capsules. Right. So we rotate with when bimanual. We are using bimanual. We used to rotate. We use the other IA probes only to rotate the lens also. Sometimes even with the digital imaging, the marks sometimes don't correspond with our actual reference marks. That might be because when the image was taken, the patient might have rotated. Thank you very much. We can discuss. No, actually that was for like rotation. You are using the bimanual IA for rotating the toric lens. So that to keep it in position, we are using the Virion on. And I was discussing Virion, the need for marking, because sometimes what happens, the patient might have tilted the head when the acquisition was taken. So Virion only gives the steep axis. That axis might not correspond when the patient is in a sitting position. So we do the surgery, and when we assess, at that time it might not correspond with the 170 degrees, because the 170 degrees on Virion will be equivalent to the 0 degrees on the sit lamp or on the sitting position. So that's the reason we always mark, reference marking is very important for every patient.
So like one way that you were rotating with the irrigation aspiration, that's a good idea. The other thing I do is sometimes, because when we are doing a viscoelastic removal, typically for toric IOLs, you want to go behind the IOL and remove the viscoelastic, and it rotates. So what we can do is we can keep the irrigation fluid on, and we can use the dialer with the other hand and just rotate it. That's the other option which comes in hand.
That comment you made about Varion, the Varion doesn't take only the steep axis, it looks at the perilimbal blood vessels.
No, all those things, but
let me complete, please. It looks at the perilimbal vessels, it looks at the iris pattern.
Yes.
So whatever position you've taken the photograph at the acquisition module in the OPD, the axis will be aligned to that image, not to the vertical or the horizontal axis.
I agree. All that.
So I have been using Varion since 2017 now, and my acquisition rate is probably 99.9%.
Good.
And the only cases which I can count on my fingers, like maybe 4 or 5 cases in so many years, the only reason why a digital marking system like Varion or Callisto will not pick up registration is if the palpebral aperture is very small, in which case you do a manual marking on the screen like you do on the OCT
Yeah,
for
there is
registration.
an option for manual marking. What you told is all right.
So you've taken it and it's registered for another patient. So that's a transcription error.
Yeah, no, as in one patient A is on table and the Varion is on patient B. And when we do the registration, it registers.
That shouldn't happen actually. Yeah, that shouldn't happen. So actually we have a list of checks to do that. But that's surprising, yeah. That's surprising.
What you told is right, but what happens is in Varion, they will give the steep axis. Whatever steep axis is written.
Steep axis you enter, you can change it. For example, the Varion picks up a steep axis.
Yeah. It will predict. No, I'm telling the what the Varion predicts the steep axis where the IOL has to be placed. That is entered. So we will mark that. Suppose some other consultant sees this is not at 170 degrees because he is seeing on slit lamp and comparing with the slit beam. So then reassessment. I am talking about the first post-op visit when the patient comes. They will see it is supposed to be at 170 degrees, but here it is at 0 degrees.
Yeah. So what I can potentially understand that potentially what's happening here is that your OPD acquisition is not, you're not putting in the figures from the Varion OPD module. You're using probably a different biometer readings into the Varion. You're feeding that into the Varion and using those axes.
No. Trying to say that the Varion has asked him to implant a lens at 170, he's implanted at 170, and when post-operatively somebody else has seen, the lens isn't at 170. They say it's at 0 degrees. So it must be a malalignment.
Yeah.
The patient may not have sat,
That's what
the
is
patient may have
happening.
rotated his head by
So when the equation was taken, it was not taken at the patient in this, like in the direct position.
The tips you have to follow.
Yeah.
It's like you are compressing your A scan millimeter. So it's garbage in, you get that. You have to make sure that.
So usually you tend to take 2-3 readings, 2-3 machines, all these things to improve our predictability. Thank you.
Thank you everyone for sticking with us till the very end, and thank you to all my panel and missing the match, more importantly. Thank you.